All right, so welcome to LGOST Think Before We Drink number 6. This is our continuation on hamstring injuries. No, 2 weeks ago, or actually 3 weeks ago, we talked about hamstring avulsions, and then now today the purpose is just to extend that discussion about hamstring strains. And today we're having Dexter, Jessica, and Abdul talk about hamstring injuries, and so they'll be presenting today. So if you guys are ready, here, let me share with you guys the ability to screen share. If you guys can't.
Dexter, do you want to do it?
Yeah, I got it up right now.
All right, perfect.
Okay, hold on. Okay, so I just made Dexter the host. All right, you should be able to screen share.
How do I do that?
I think the green button that says screen share at the bottom next to chat.
Oh, there. See. All right, so here we're going to talk about hamstring strains today. So, oops. Abdul, did you want to start or?
Yeah, sure, I can start. Hamstring muscle injuries are the most common injury in the world, actually. And one of the most recognized risk factors with hamstring strains is actually a prior hamstring strain. That's the only correlation between any risk factor that is statistically significant. There are some other studies that observe some muscle length issues and some flexibility issues as a risk factor. Some studies kind of saw age as a risk factor, but they did see that the ages of after 23 were the highest risk. 23 to 25 is where they saw the highest kind of spikes in incidence. This injury is the most common in soccer or football. And it's found inside the English leagues. African athletes have the highest risk of injury. And then when they looked at Aboriginal athletes in Australian soccer leagues, they were statistically more significant or significantly higher risk. So one thing I want to kind of point out about this particular point with the African athletes and Aboriginal athletes is the current climate that we're in with, we kind of chatted about this before, is I kind of looked at this point a few times because I was like, why is it that African athletes and Aboriginal athletes are at higher risk? And I feel like it's not just a genetic issue of their muscles are weaker or whatever it may be. I feel like there is some health disparities that may kind of point to these minorities having a higher risk of injury. So I feel like that would be a point I would like to kind of look into and research a little bit more. And then right here on the side, I have a picture of Chris Paul, and you can see his injury history there. And just so you guys kind of have a picture of how kind of recurrent, how much this injury can recur. You can see that in like hamstring is kind of a common theme here, and then where it says knee and leg, you don't really know the specifics on what and where that is. So I feel like that's just kind of like just to give you guys an idea of what, you know, like how often this kind of injury happens. So can you go to the next slide? And then, as I mentioned before, it is the most common injury in sports because it is the most common muscular injury in soccer. In this video I have right there is a pretty good mechanism, which Dexter is going to go into a little bit later. the incidence rate is actually increasing 4% per year, and actually happens more commonly in practices versus games. So that was something kind of interesting that I saw. I feel like it could be related to the kind of constant moving, and like there's no the practices are a little bit longer and a little bit more specific with the training versus games. Hamstring injuries actually have a pretty long rehabilitation time, and they have a really high re-injury rate. So the typical kind of number that I saw was 12 to 33%, which is kind of a big range. But there were some studies that reported 60 to 70% re-injury rate in subsequent seasons, depending on the sport. Again, a lot of these studies kind of looked at soccer because that's the most common sport where this is injured, but there were studies that looked at the NFL and the NBA. So I feel like it's kind of like an overall theme here is it has a high re-injury rate, and if it's not rehabbed correctly, it can, and it multiple re-injuries. So like after one season, after 2 seasons, after 3 seasons, that we're going to go into that a little bit later too. For the next slide, please. I dedicated an entire slide just to Nordic hamstrings because of how important and how good the research was related to this specific exercise. So I was really, like we've all kind of heard of this exercise. There was a big trend on Instagram a little while ago. But doing Nordic hamstrings significantly reduced the rate of re-injury. And some studies, like this Van Dyke et al. Study in 2019, looked at up to 50% of reduction in re-injury. So that's a pretty big deal, and I feel like should be pretty common practice to include this when you're kind of dealing with somebody that has some hamstring injuries. There was a drawback though. It didn't reduce the severity of the hamstring strain. So whenever 2 people with using this kind of intervention or not using this intervention had the strain or the injury, there wasn't a big difference in how long they were out for. But on the other side of that, even a 4-week, 8-session program was pretty significant in reducing the injury rate. And that video that just played is pretty much how it goes. It's a bit eccentric loading of the hamstring, and then they kind of come up themselves. And there's a few different variations, but that's essentially what it is: eccentric loading of the hamstring. So next slide. And then the kind of rehabilitation. So this video, before it kind of goes away, is just some examples of some agility training, trunk control, rotation, things like that. So obviously the rehabilitation changes with each grade. You have 1 to 3. Static stretching 4 times a day. So there was a study that looked at static stretching. They stretched 1 or 2 times a day versus 4 times a day, and the return to sport time was lessened by 1.7 days. So I mean it's decently significant if you're a pro athlete or something like that. And then including a functional rehabilitation program versus kind of the traditional strengthening and stretching of the lower extremity. Functional rehab included agility and then trunk stabilization, and it reduced the recurrence of the strain by 47 to 60% within 1 year. And this was compared to another group that saw the injury come back within the first, I think it was 6 weeks. I can look into that a little bit more and get the specific numbers. And then full thickness tears, although they took a lot longer to kind of return, which is 5 to 6 months, the recurrence of the strain was next to nothing. So it wasn't as serious of an issue, which makes sense because a full thickness versus a partial, like you need to kind of do a lot of the retraining. I mean, you'd retrain in both, but the mechanism was a little bit different.
All right, so moving on to mechanism of injury, majority tends to be non-contact, especially during running and sprinting. And this mainly happens during the terminal swing phase prior to foot contact. And this is because there's a high eccentric demand on the hamstrings and decelerating that limb. And this mainly affects the biceps femoris in a greater proportion, since with greater running speed, the biceps femoris activity increases in relation to the semimembranosus and semitendinosus. So, and then this injury also tends to occur along the intramuscular tendon. You can also get this injury through extreme stretching. So especially with like hypermobility, this type of injury tends to happen with the semimembranosus and usually occurs at the proximal free tendon versus the intramuscular tendon. So moving on to differential diagnosis, kind of things to consider before you kind of diagnose it as just a hamstring strain. You want to consider whether it's a hamstring tendon avulsion. So kind of looking at the mechanism of that, it tends to be a little bit more of a traumatic onset. So someone will report a forced hip flexion and knee extension combo, kind of like during a water skiing accident or during some sort of slip and fall. Usually following the injury, they'll have an audible pop, or they'll have significant pain and a significant loss of function immediately after the injury. So things to look for is whether they can perform a prone leg curl, whether they can fully extend the knee, or whether they can bear any weight on the affected limb. So combination of those things kind of gives you a little picture that maybe is a little bit more serious than just a hamstring strain. The ecchymosis prior or post injury is kind of a giveaway as well. And then to confirm it, you can also look for a palpable defect or what's called a bowstring sign. And you'll see the distal muscle kind of bulge because it's retracted due to the avulsion. And then MRI is the best way to accurately diagnose this. And then when you're dealing with the younger population, you also want to consider an ischial-apophyseal avulsion. So this one tends to happen in the adolescent age, 13 to 16 years old. Usually occurs with a forceful but low velocity, kind of an overstretch. Again, same with the hamstring tendon avulsion, you'll get an audible pop, and they'll complain with deep achy pain, and they'll have a real hard time sitting. Also, you want to look for pain and tenderness in the ischial tuberosity, and then extreme pain and weakness with hamstring and glute testing. They'll have pain with passive and active knee extension, and usually you can find this with an X-ray. Next, and then you want to also consider maybe it's a proximal hamstring tendinopathy. So the onset for this tends to be more insidious and gradual. They'll have pain with activity, but they'll also have a hard time sitting on prolonged surfaces because they just can't sit on that ischial tuberosity, or it'll develop with prolonged sitting. And there are some extra special tests to kind of tease out whether it's more of a tendinopathy versus just a hamstring strain. I attached a video here for reference for the bent knee stretch test. So basically with that test, the patient is lying supine and you're taking them to a full hip flexion, and then you're slowly extending the knee. And you're looking for a symptom reproduction in the ischial tube. The Prana and Orava test is kind of similar, except you're standing and then your foot's on a bench. And it's kind of like you're having them perform a standing hamstring stretch. And again, you're looking for symptom reproduction in the ischial tuberosity. And then, like anything else, you also want to be wary of maybe any referred pain coming proximally from the low back SI joint or some peripheral entrapment. So kind of paying attention to the quality of pain, whether they're dealing with any cramping, numbness, tingling, or maybe shooting pain. You might want to rule out the low back or SI joint. So things to test whether it's more of a proximal origin is whether they have pain with lumbar range of motion or lumbar provocation testing, or they have tenderness with SI joint stress testing. And you also want to check if they have any neural tension or pain with lumbar spine extension, quadrant testing, kind of things like that. So just other things to consider before you diagnose it as a hamstring strain.
All right, so I'll be talking about prognosis and some return to sports guidelines. All of my information is from an article by Erickson et al. From 2017, and I can email it to Phil and he can disperse it among everyone. It's pretty comprehensive, and at the end actually has an algorithm for determining return to sport. So, and that's what I'll go through at the end. For prognosis, so like you said, MRI is good at detecting any sort of tears or anything. Multiple studies have supported that an increased length of the injury and amount of cross-sectional area of the injury seen on MRI. The more obviously area of the injury, the longer it takes for it to recover. Same thing with any T2 hypersensitivity, which indicates edema. It was also associated with a longer rehab time. A lot of studies, though, were not able to support MRI in being effective at predicting any re-injury, and I'll go over that later when we talk about return to sport. In terms of sonograph or ultrasound, in 2004, Connell et al. Showed that sonograph showed similar findings to MRI in terms of how much tissue was injured immediately after the injury and 2 weeks post-injury, but then had slightly less similarities at 6 weeks. So suggesting that MRIs might be more sensitive later in the recovery. But then later in 2014, some more recent findings, a study looked at 51 soccer players and they performed ultrasound imaging within 10 days after their injury. And the findings on their ultrasounds had no correlation with the number of days they missed from soccer. Ultrasound, sonograph, it kind of take it with a grain of salt in terms of how much it relates to how long people are out. Oh, what do I press? Okay, some more factors for prognosis. Gulido et al. In 2014 kind of came up with this group of factors that were associated with greater than 40 days length of time to return to sport. And these were all factors they assessed within the first 5 days of their injury. And this is based on data from 120 athletes, so pretty high, good number for subjects. So this includes an initial pain score greater than 6, pain during everyday activities greater than 3 days, if they felt or heard a pop during the injury, any bruising, and then a more objective measure of greater than 15 degrees difference in passive knee extension. So trying to lengthen that hamstring and if there's significant difference compared to the uninjured side. Another possible prognostic factor is this time to walk test. So this assesses an athlete's ability to walk without pain post-injury. And they found that athletes who took more than 1 day to walk pain-free were 4 times more likely to take longer than 3 weeks to return to sports. Some other tests for prognostication, the active range of motion test. So this is where the patient has their hip flexed at 90 degrees in supine, and then they try to extend their knee and straighten out the knee. And athletes that had greater deficits took a longer time to recover. Resisted range of motion test is basically just resisting the hamstring, MMT essentially. Athletes with recent hamstring injuries had significantly decreased knee flexion torque, so they weren't able to generate as much force at lengthened ranges, so when the knee was almost fully straight. And athletes had a better prognosis with full isometric knee flexion force at 90 degrees than those with reduced force. Some other things to consider for prognosis, point of maximal tenderness. So this just means location of pain on palpation. So the more proximal their pain was to the ischial tuberosity, the longer time it took for them to return. which kind of makes some sense if we think about tissue healing. If you think you're closer to the ischial tube, you're more on tendon. So tendon can take 1 to 3 months for that full collagen maturation. So you're thinking along those timelines from tissue healing. And then moving on to the next point, injured tissue type. So intramuscular tendon or adjacent muscle fibers typically are shorter recovery period than free tendons. And again, it's kind of the nature of what tissue is affected, right? Whether it's tendon versus more myotendinous or muscle fibers. And then mechanism of injury, Dexter went over the more sprinting type versus stretching type injuries. And those with more of a sprinting type injury, they averaged 23 days to return to sport. And those from the stretching averaged a little bit longer of a 43-day for a return to sport. All right, so as I mentioned earlier, this Erickson article, the authors got together and kind of reviewed all the literature and came up with this return to sport testing algorithm. Basically because there's no real consensus within the literature of a set protocol for, these X, Y, and Z things, determine when someone's ready. So they kind of went ahead and did that based on the research they found. So the first thing was, like I mentioned, the tenderness to palpation. They found that athletes with localized discomfort on hamstring palpation at the time of return to sport were almost 4 times more likely to sustain a re-injury. So if you're finding that your athlete is still sensitive to deep palpation at their injury site, then they're probably not ready to go back to sport yet and need some more rehab. Another thing is strength. So this is based on more isokinetic testing, both under concentric and eccentric conditions, but you would want a deficit of less than 5% compared to the uninjured side. But you can also use this percentage if you're just doing isometric dynamometer testing as well. So the active hamstring test, or the H test, I had actually never heard of this test until this article, but it's where a patient completes an active straight leg raise on their own as fast as they can to the highest point they're comfortable going. It's more of a test of insecurity because people with hamstring injuries probably don't want to do that, right? So if you find that they're insecure or don't go as high with the affected limb, then they probably need a couple more weeks of rehab before you get them back to sport. 95% reported insecurity with this test on their injured leg compared to their uninjured. And it's been shown to be a valid and reliable test for detecting deficits in athletes with hamstring strains. So moving on through the algorithm, the next thing is a single leg bridge test. So they found that a score of 20 reps or less, the soccer players were found to be at an increased risk of hamstring injury. So, doing at least 20 reps, they recommended in this algorithm that 30 reps is suffice to clear someone to go back to sport. And then the last thing I wanted to mention was the MRI studies and how they are not as good at predicting whether someone is more likely to re-injure. So they did a study, Runick and all, found that 24% of subjects had fibrosis on their MRI and had a re-injury, and then also 24% had no fibrosis and also sustained an injury. So any sort of signs of healing or still some injury at that hamstring didn't necessarily predict if they were still going to re-injure that hamstring. So I guess the bottom line from that is that clinical and functional tests seem to be better associated with detecting return to sport and risk of re-injury than imaging for those later stages. And I think that's all we have. So here's our references, and then like I said, I'll send that Erickson article to Phil, and he can distribute that to everyone because I think it's pretty good. Or if anyone wants any of the references, or we can send those out. Cool.
Awesome. Thank you, Abdul, Dexter, and Jendo, for sharing your research on these hamstring injuries. I think that was very helpful for all of us to understand where we're at in terms of clinical practice guidelines and seeing how we can treat hamstring strains. I do want to ask you guys, are there any patient cases that you would like to share that kind of like boggled your mind about when you're rehabilitating hamstring strain injuries? Just any case that comes to mind during your practice.
I'll go. In my time here at LGOST, I've actually only seen one, but it was unique in that she was actually a fencer. And so if you think about the motions of fencing, they're always in like a lunge position with one leg forward, one leg back, right? They never really switch. And it was her lead leg where she like stepped forward and kind of like overstretched her hamstring essentially. And so I did notice that she was younger, and it did take a little bit longer than I would have imagined a normal hamstring strain to take. But after reading the research and things, it kind of makes sense, just like with the mechanism of injury, when I look back on it now. So that was my one clinical case.
Got it. Dexter and Abdul, anything you guys want to share?
I had one patient when I was a student though, who had a hamstring. Hamstring strain, a pretty acute one, and then I didn't really put together at that time the fact that he's had 3 prior ones in the last 2 years. He was a wrestler. But now that I've kind of done this research and kind of looked into it a little bit more, there are definitely a few things that I would have changed now that I know the information I do know now. But yeah, it's kind of crazy when you actually see a lot of, because even 70% at some point, like there were some studies that says 70% recurrence rate. Like I thought that was pretty insane. But then now I think back about that guy who had 3 in like 2 years or something like that. And a lot of the time it wasn't even like, so he was a wrestler initially, and then he stopped wrestling. And then the time where he saw me, he was playing in like football with his friends and then just re-strained it. So now I'm kind of thinking about that recurrence rate and how serious and like how legitimate it is, because I actually saw it like in person. So that was something that kind of popped out to me.
Got it. I see. Dexter, anything from your experience? No. Yeah, I'm just curious, like because I'm an athletic trainer and I'm assuming everyone on here is a physical therapist. I want to kind of know from your guys' clinical rotations or in your clinical practice, is seeing hamstring strain cases pretty common, or is it just really depends on the area that you're in or what specialty that your clinic is?
I feel like it's just when I was growing up, when I had a few strains, PT was never the first thing that would come in mind. In addressing it, it was just like, all right, I'll let it heal and then go back at it again. So I feel like it happens a lot, but I don't know if a lot of people are willing to go to PT for it. So I haven't seen it a lot, even though I know it happens a lot. I saw it happen a lot when I was working the track meet with you, Phil. But
yeah, we definitely see it firsthand at more in the acute nature. But I guess like hamstring tendinopathies, I would imagine you guys would see that more often than hamstring strains, or even hamstring tendinopathies, those are just kind of like that. I feel like the patient would also just kind of be on the fence of like whether they should be seen or not, and kind of try like home remedies, or maybe they go on Instagram and find like, oh, okay, maybe I heard Nordic hamstring exercises might help out too. But yeah, I feel like it's just kind of like a weird trend that we don't see, or in the clinic, we don't see a lot of like hamstring strain injuries just coming in to be treated, unless if it's maybe
Yeah,
like,
and I wonder if that's what
yeah.
contributes to the high re-injury rate. Maybe, people like Dexter said, you strain it and then you think, oh, it'll just go away on its own, but then they go back to whatever activity and it's that tissue's not ready for the load yet, and so then it restrains, right? But they don't feel the pain anymore, so they think they're ready, but then no one actually, gets the treatment from it, after, first or second time. Or so that could be why I was thinking to myself, why would the recurrence rate be so high? But then that maybe makes sense, just people not seeking treatment. From what I could tell, because we had a talk about hamstring strains with the sports fellows. They did kind of like a journal club, kind of like we do, and they're all D1 sports fellows and residents that put on this talk, and they talked about them like they see them all the time, but I think it's kind of like you, Phil, where they're there with the athletes, like at the events, at the practices, so they see it happen firsthand, and then they follow them through their rehab to get. Unless you're working like directly with a team like you do on the sidelines, or with a program that you're seeing the athletes from day 0 to return, then you won't see them as much clinically. That's kind of my that's my guesstimate.
Right. So from like a preventative standpoint, what do you feel like has to really happen in order to reduce maybe even like the re-injury rate of these? Because it seems like just at first hand it just doesn't really seem like a big deal, but now that we kind of see like the re-injury rates and seeing like how there's a lot of different symptoms and signs for these hamstring injuries, like what do you guys think would be like a preventative intervention and trying to address the issue for hamstring strains?
I think any running, cutting, any sport that requires any of those movements, it should be common practice to include Nordic hamstrings in every pre-game, pre-practice, anything like that. When they're stretching, they should be doing Nordic hamstrings, because again, the evidence and the research is kind of insane. Because if you go to PubMed and look at articles, and it's not even just PT, AT articles. These are medical articles, orthopedic surgery everywhere, from every profession that is saying Nordic hamstrings do so much to prevent this. And some studies are saying prevent it completely. Some are saying 50%. Some said like 25, but still, like, that's pretty significant. And I think that any sport that kind of has those motions or movements should include Nordic hamstrings in their kind of pre-game practice, everything.
Got it. Yeah, I totally agree. I think just all the research that you presented, Abdul, and just what's going out there to the public, and I think just the injury prevention program and being able to get the patients to buy in. I totally agree, and I think it's just alarming that, or I shouldn't say alarming, but I think it's just remarkable seeing that that across all the healthcare professions, they're all seeing the effect that Nordic hamstring exercises have on reducing this injury rate. So it's like a no-brainer. It's like, why not, right? So I find that pretty cool, and yeah, why not? Why don't we implement this? Oh, so it looks like, let's see. Oh, sorry, Dexter, did you want to say something?
Well, Well, I've talked to my patients in passing about what they think they should do, because occasionally they'll ask me about, oh, I strained my quad or strained my hamstring a while ago, and I was wondering what I could do about it. And a lot of their impression is they need to stretch more. And I think that's just a general consensus in the population is, oh, you're too tight, you need to stretch a little bit more. And I think there just needs to be a little bit more education. No, you need a little exposure to more of that eccentric loading or some sort of loading to build the tissue up, because you need to precondition it to handle those loads again in their sport, especially with high speed running. It's a high demand on those muscles, and then if they're not ready, even if they don't feel pain now, if they haven't been exposed to those kind of loads before, then that's kind of where the re-injury can come from.
Right. Have there been any studies that show like that they put like a quantifiable measure to, like, let's say tensile forces on the hamstring, besides just relying on like MMTs? Has there been any studies about like how much force would it take to really strain a hamstring?
That's a good question. I feel like that it might be individual to each person too, right?
Yeah.
Everyone's different size, different speeds. So
Yeah.
I don't know if you can have a one size fits all.
Yeah. Or like this number of force production will prevent you from getting any type of injury, right? I don't think you can simplify it that much, because like Dexter said, it's based on what are the demands on that muscle that person needs, and at what level, right? Like, are you talking about like a recreational person who just wants to do sprints for, getting in shape, or are you talking about elite level sprinters, right? Those are a little bit different in terms of demands. So yeah, I feel like quantifying force that simply wouldn't kind of would be difficult to do.
Right. And I feel like it would just go back to the whole message of just perhaps comparing bilaterally, right? And just seeing like where I guess we wouldn't be able to quantify, like, if we're not at this force level pre-injury, then we can't really predict the injury that way, because everyone's different, right? But as far as like once the injury occurs and you go through the rehabilitation, the best valid measure I don't know if you guys would agree, is just comparing bilaterally to how much force that you guys measure from the hamstring strength, right?
So there was one of the studies I looked at that was how they predicted that the Nordic hamstrings were so effective, or not predicted, like they found out the Nordic hamstrings were so effective, were a couple of things. Where obviously, like, they followed a group of athletes over their season and a couple of seasons, and they saw that, hey, their injury risk or their injuries were reduced to a significant amount. But there was one study that looked at like the muscle physiology, and there were some factors that were studied, but they weren't necessarily like, it wasn't like set in stone that this is a reason that causes this, just like Dexter and Jendo were saying. But they looked at eccentric peak force of the hamstrings, the isometric peak torque, eccentric peak torque, isometric peak torque, and then the functional hamstring to quad torque. So those are three numbers that they looked at, that they saw that. So what they did was they saw that the Nordic hamstring exercise positively affected these three torques. And there was a few other things. And they are, making an assumption that those three torques could be the reason why the hamstring strain was less. There was also because they were looking at the penne angle. I had to look into that a little bit, but basically it's the angle in which the muscle fibers are pulled towards the tendon as the muscle is being stretched. So they said that could be another reason, but then again, the research was really they didn't really know too much. But yeah, those three torques that I just mentioned they're suspecting that those three torques are the three numbers that could be reducing the injury rate. but
Like you would
again, it's
say,
speculation.
right. So like you would say like with those three torques in combination, or like you have to have, or it's okay to just increase like the eccentric torque of it and not
So I think they saw all three of those increased.
value.
At those three increased, I don't think they were able to differentiate each individual one, but they just saw like, hey, Nordic hamstrings increase these three torques. Could there be a possibility that these three torques are the reason why people have hamstring strains? You know what I mean?
Right.
So yeah,
There wasn't
again,
any
nothing.
like causative relationship to it, right?
Right.
Got it. Okay. All right. Well, we have Elliot here. I know he kind of hopped on right when it started, but Elliot, if you have any questions, feel free to ask, or if there's anything that you want to share from your experiences, yeah, feel free to hop on and share. If Elliot's there.
Oh yeah, hello.
Hi.
Hi, yeah, sorry, I was driving.
Oh, sorry if I
So-
distracted you, but
No worries. Yeah, I'm just driving, listening in to everything. I'm practicing down in San Diego. I went to school with Abdul. Yeah, so I think the one thing that stands out to me that you asked about how patients and the recurring injuries, the one thing that I've come across is, I think Dexter touched upon this, is that everyone is just like, oh, I just need to stretch more. And I think I agree with Abdul with education. I think is the most important thing with people who especially are dealing with these recurring hamstring strains. I had a couple patients. One of them was like an old rugby player, and during the eval, all he was saying was, "Oh, I've had these before. Oh, they go away," and it just seemed like he was accepting of the fact that he gets them, they go away, and then he gets them again. So I think just teaching him like, hey, no, these are things that you need to do, and it's not just you deal with the symptoms and then the symptoms go away and then you go back to running again. You need to hit these certain criteria. So it's very helpful learning about like the single leg bridge with the 30 reps with those, and just different factors that they need, or different criteria that they need to hit in order to return to whatever they want to do.
Awesome. Cool. All right. So I think before we wrap things up, it seems like I don't know what happened to, was his name Trison or Treason? Is that, I'm assuming you know him, Abdul.
Yeah, he had to go. He messaged me privately.
He had to go. Okay. All right. Well, either way, I think before we wrap, I would like Abdul, Dexter, and Jendo just kind of share like what was the one thing that you thought was really interesting doing all this research and then presenting. Like, what was the one thing that you guys thought that was new to you and you could apply it to your future practice?
I think learning about specific criteria that we can shoot for instead of just like tensiometer testing, also like single leg bridge, the active straight leg raise, kind of more tests just to assess like the tissue tolerance and how ready they are to return to their sport. I think that's always helpful. Just helps with confidence and decision making.
For me, I thought it was useful, or for future practice, to have some of the data on prognostic factors. So, type of injury, location of palpation, all those factors. So in your mind, you can already think, okay, this person is going to take a month to get better versus 2 to 3 months, right? Just knowing all those different things, and whether or not, MRI, ultrasound is useful or not. I know at the elite levels, they get MRI or ultrasound pretty much right away, but more clinically, people might not, so sometimes educating patients based on the research, this is why or why not your doctor didn't do an MRI. So just knowing some of the background on that for my own knowledge in terms of, determining number of visits and length of treatment, but also for patient education on, you had this type of injury, this is where it seems to be affected, this is how long it might take.
I think for me, the biggest thing was the fact that the Nordic hamstrings were such an effective intervention, and I guess you don't even have to do it that many times for it to be effective, which I thought was pretty astonishing. So I think for me personally, I think if I ever, like, again, if it's appropriate, if I have lower extremity, patients with lower extremity injuries, including Nordic hamstrings, and like, cause as a general, just, hey, like, prevention type thing, I thought that was something that I feel like if I could implement it, I will.
Awesome. Cool. Well, once again, thank you, Abdul, Dexter, and Jendo, for presenting today on the hamstring injuries. Yeah, so what will happen is I will get articles from Jendo from what was discussed in the presentation, and then I'll send those out to everyone just for their reference, and then be able to upload this video on YouTube. And then we'll talk about future dates for the Think Before We Drink and Think and Drink sessions. If you guys are interested in attending this Thursday's Think and Drink, it's going to be on heat tolerance testing, just in lieu of the summer weather. So I thought it'd be a good topic to talk about. But if you guys are interested, feel free to reach out to me. And once again, thank you for coming out to our Think Before We Drink, and we'll see you next time. Thank you.
Thanks, Phil.
Thanks, Phil.
Phil.